Good afternoon. Thank you, Chairperson. Thank you to the audience for joining me at the World Federation Hemophilia Virtual Late-Breaking Abstract presentation. Here is my disclosure. Most of the comprehensive hemophilia treatment centers have established their own hemophilia patient registry. It is useful for data analysis of individual patients at institutes. We have established our hereditary bleeding disorder registry since the year 1999, written by Microsoft Access. It consists of 3 parts, namely patient, carrier, and information for the World Federation of Hemophilia annual report. These are 3 sheets of annual report for which the treatment center was requested to answer at the end of each year. Our registry was decided to have the patient output data printed out at the end of each year for convenience. The section of patient from our registry has been modified to be Disease Management Information System for the National Health Security Office of Thailand when the Nationwide Corporate of Hemophilia started in the year 2005. It has been used up to now. The Thai Society of Hematology have created a hemostasis registry, including patients with hereditary bleeding disorders and thrombosis in this year. You can compare the similarity of the detailed data entering of these 2 registries. Right now, we use the brand new registry of the Thai Society of Hematology, Hereditary Bleeding Disorders Registry nationwide. I will call Thai Registry in short. However, the World Federation of Hemophilia had launched the World Bleeding Disorder Registry, WBDR, since the year 2018. The physicians interested in both registries face the constraint of double data entering. So the objective of our study is to create a connection between our local registry to the World Bleeding Disorder Registry of the World Federation of Hemophilia. The purpose is to avoid repetitive data entering and have the hemophilia patient data automatically transferred. We use the computerized program of PHP and MySQL. We have studied the data input of both registries. The minimal data set of WBDR includes 3 parts. First, baseline data contains demographic and clinical history data. Second, baseline visit contains retrospective data of the patient in the past 6 months from the baseline visit, which can be the date of registrations. And third, follow-up visit contains data since last clinical visit. This slide shows you the detailed data input of the Thai registry containing personal history, hemostatic test, inhibitor assessment, vaccination, hospitalization, early bleeding treatment, so-called home treatment, prophylaxis, immune tolerance induction, musculoskeletal assessment, quality of life, and patient status. The next 2 slides, I will show you how to complete baseline data of the WBDR. Here is the baseline data sheet, which can be simplified as country of residence, date of birth, sex, age, hemophilia A or B, severity of severe, moderate, and mild, factor level in percentage, age and manifestation of first breed plus joint breed, and mutation. The data of personal history and hemostatic tests from the Thai registry can be captured to complete the baseline data of the WBDR. Next, I will show you how to complete the baseline visit and follow-up visit of the WBDR. These are the data sheets. They are similar. Baseline visit contains data of the previous 6 months, while follow-up visit contains ongoing data. Both baseline visit and follow-up visit of the WBDR contain date of hospitalization, early treatment, prophylaxis, and ITI concerning the total number and location of bleed, target joint, and the treatment received of blood component and factor concentrate. You can capture information of bleeding and treatment from the Thai registry of hospitalization, early bleeding treatment, prophylaxis, and ITI. You can capture the number of joint bleeds, muscle bleeds, central nervous system bleeds, and other bleeds. How many are trauma-related? The summation will be the total number of bleeds and location of bleed. This slide shows you the Thai registry of bleeding manifestation at joint, central nervous system, and muscle. What is the cause? Spontaneous or trauma-related? Furthermore, the Thai registry of hospitalization contains admission date, discharge date. The subtraction plus 1 will be the day of hospitalization. Also, the total amount of replacement therapy of blood component and factor concentrate are shown here. Since the Thai registry will connect to the WBDR on an annual basis or at the end of each year, we will obtain an annual report for each patient. It contains patient recent baseline data, annual hospitalization from the summation of episode and day of hospitalization during 1 year period, annual bleeding rate calculated from baseline visit in the previous 6 months, and follow-up visit for the current years. Similarly, for the annual joint bleeding rate, annual replacement is the summation of the total used blood component and factor concentrate during 1 year period. Finally, it reports the recent patient status of follow-up, refer, or death. Thank you for your attention.
Hello to everybody, welcome to my presentation. My name is Silvia Riva from the University Hospital of Milan, but actually I'm now working and I move in UK at the St Mary University in London. This is the disclosure form. So, today the management of patients with hemophilia has dramatically changed due to different factors. So the availability of more and safer treatment products, the presence of specialized hemophilia center. A direct consequence is that this type of patient have currently reached life expectancy close to that of males in the similar and general population, so that more and more of them attain older ages. As a result, we now face the novel presence of a cohort of elderly patients who carry not only the comorbidities related to hemophilia, like arthropathy or chronic viral infection, but also the multimorbidities associated with aging. With this background, the general purpose of the SPHERE study was to compare patients with hemophilia and their unaffected age peers, not only for the clinical status, but also for the psychological status, including quality of life, emotional, functional, and social proficiency. In this presentation, I present data for the psychological data part. The study had the endorsement of the Italian Association of Hemophilia Treatment Center, involving 14 hemophilia centers in Italy and 6 general practice clinics. The research design was a prospective longitudinal study. In terms of enrollment, patients had an age equal or greater than 60 years, severe hemophilia, type A or B. Control had an age equal or greater than 60 years, and in this presentation we report data from baseline assessment. The set of tools involved in this research was wide. We used the European Quality of Life 5 dimension, the EQ5D, is a generic tool that provides a single value as index of patient health status, spanning from 0, the worst health state, to 100, the best health state. We use the WHO QOL for old, is a generic tool that gives an overall description of health, emotional and social status. We use the MI QOL elderly, used only in the patient with hemophilia group, is a specific instrument to assess hemophilia specific characteristics, a specific tool evaluating many dimensions such as physical health, view of yourself, feeling, coping with the disease, treatment and future expectation. We use the activities of daily living, the ADL scale, which include the basic activities that people do every day without assistance, for example, eating or getting dressed or toileting. We use the instrumental activities of daily living, which include more complex activities such as cooking or shopping, managing money. And finally, we use the geriatric depression scale to assess the presence of depression symptoms and emotional status of our patient and controls involved. So let's start to see the main results. The study involved 102 patients with a mean age of 64 and involved 204 control with a mean age of 65. Pertaining to the impact of quality of life assessed with a disease-specific MI QOL, patients with hemophilia show the highest impairment in the dimension of physical health, physical activity, and view of yourself. So, concerning physical health, patients show difficulties in moving arms or legs, walking. Other problems involve not traveling as desired and not always coping well or in a not sufficient way with the disease. Let's see now the comparison between patient and control. Quality of life, to the left, was worse in patient than in control according to the generic EQ5D, the QVAS. These results could be related with the perception of pain and increased problem in mobility, which are generally quite important in patients with hemophilia due to arthropathy, particularly in patients with an older age. With a more specific WHO QOL to the right, let's see the comparison between patient and control. So higher score in this questionnaire indicate a better quality of life. Patients with hemophilia in blue show the highest impairments in the domain of death, while control report more impairments in the domain of sensory and intimacy, suggesting that patients with hemophilia were more concerned about death and future, while control were more worried about loss of aging of sensory capacity and to have personal and intimate relationship. At the emotional level, the degree of depression was higher in patients than in control, the first blue arrow, while pertaining the functional status for simple activity or daily living as measured with the ADL, patients show slightly lower mean than control, but for more complex activity measured by the IADL, there were no differences between patients and control. So, all in all, this report provides a snapshot of older patients with hemophilia pertaining to the quality of life, functional and emotional profile in comparison with age-matched peers without bleeding disorder. So we can say that the two cohorts were broadly comparable for several aspects pertaining quality of life and functional assessment. However, there were some differences in the domain related to the emotional status, where older patients with hemophilia show a higher degree of depression. And there were also some differences in some area of quality of life, for sensory, intimacy, and death and future. So, as we know, new treatment, new drug for treating infection have dramatically changed the chronic viral infection of patients with hemophilia, who are now well controlled both for HIV and HCV. Arthropathy is also being ameliorated by joint arthroplasties and by also the presence of multidisciplinary programs that are now tailored to the needs of older patients with hemophilia. On the other hand, older patients with hemophilia seems now have more problems in terms of self-care functioning and also at the level of emotional and feelings. And so this snapshot remind us the importance to monitor psychological and well-being over the time, particularly in the cohort of patients of elderly age. In conclusion, the quality of life and functional capacity of older patients with hemophilia were similar or only marginally lower than those of their age peer without hemophilia. These results emphasize the role of specialized and comprehensive hemophilia treatment center, as well as the specific program means to make aging successfully in patients with hemophilia, play to reduce the gap with the age-matched peer without hemophilia who receive standard care by the general practitioners. And this report also underlined the role of psychology in this type of patient and the important to monitor over the time also psychological and social aspects related with everyday life. I want to thank you all the group involved for the data collection, 14 Hemophilia Center. I thank you also for your attention. If you need our information, please let me know and write me an email. Bye bye.
Good afternoon, ladies and gentlemen. It's a great pleasure of mine to be with you today. Thank you for the World Federation of Hemophilia to arrange such a meeting in such circumstances. And thank you for them to give me this opportunity to meet you once again and to share with you our data about the prevalence of bleeding symptoms in young adults in Al Medina, Saudi Arabia. This is my disclosure. Bleeding disorder are a group of disorders that affect the pathway that control the bleeding. Where any defect at this part, it may lead to a defect in the hemostasis, subsequently a hereditary blood disorder. For example, when you have a defect in the blood vessels, endothelium, collagens, like in Ehlers-Danlos syndrome, you will have bleeding tendency. When you have a problem with the von Willebrand factor, you will have von Willebrand disease, whatsoever the type of it. When you have a problem with the platelets, either the number or the function, you will have thrombocytopenia or thrombocythemia, where it will affect your bleeding control. Phospholipids, coagulation cascade, any part of those will be defected, either deficiency or functionally defected. It will lead to a bleeding disorder. Natural inhibitor or fibrinolysis, again, though they are causing thrombosis, but they may lead to some sort of bleeding disorders. So any defect of this part or this cascade, it will lead to a bleeding disorder. For example, this is just examples of them. Some of them, they are very common. Some of them, they are very, very rare. For example, hereditary hemorrhagic telangiectasia, which affect about 1 in 5,000 of the population, while in hemophilia, it is 1 in 10,000. This is more common. Von Brand, it is 1.3% of our population, but look to the factor 13 deficiency, where 1 in 4 million affected by factor 13 deficiency. So some of them are really rare, like factor 13 deficiency, and some of them are more common. The inheritance is different. Most of them, they are inherited as autosomal recessive disorders. Some of them, like in hemophilia A and B, it inherited as X-linked or autosomal dominant, such as von Willebrand. And again, for the presentation and symptomatology, some of them, they will bleed superficially, mucocutaneous type of bleed, epistaxis, or oral bleeding like von Willebrand disease or platelet disorder, or they are deeply seated type of bleeding like in hemophilia when they bleed in the joint, or intracranial hemorrhage, or GI bleeding such in factor 13 deficiency. The matter is different here in the Middle East, where bleeding disorder, hereditary bleeding disorder are much more common than the Western or Eastern side of the world. In Al-Madinah, we have reported plasma thrombectomy as the prevalence of 1 in 30,000. Our friends in Iran, they have reported 1 in 200,000, while the incidence in the West, it is 1 in a million. Again, for factor 13 deficiency, we have reported our prevalence are 1 in 170,000, and factor 13 deficiency in Iran has been reported on 1 in 160,000 of population, while in the West, they have reported the incidence of 1 in 4 million. So it is more common among our nations. This is just an example. In this study, we have run a population-based survey where we are surveying the people whom they suffer of the bleeding tendency symptoms. And this is part, actually, of the a bigger project, which is the pattern and prevalence of bleeding disorder in Saudi Arabia. And this has been funded by CACS. And what I'm presenting today is part of this project. This project consists of 2 parts. Phase 1, where it's questionnaire-based survey among the students whom they are 16 to 24 years old, and those students whom they tend to be positive response regarding the symptoms. I'm talking about significant symptom. So we will run for them BT, BTT, and BFA at bench side. And then we tend to the next step, which is phase 2, where we are going to do whom they tend to be positive. I'm talking about the laboratory positive. We will analyze what type of disorder and subsequently molecular sequencing for those people. What I'm presenting to do today, it is the phase 1, which is the symptoms in Al-Madinah region, which is part of the project. This is the research committee approval, and this is the consent for each patient. And this is an Arabic flyer, which explains the project for the people whom they are going to enter the project. And this is the 2 versions of the questionnaires, Arabic and English. And actually, it is run by an interviewer whom they have been trained to it, and depend on what the candidate would like to run, English version or Arabic version. 680 students has been enrolled in this study. 56 of them, they are females, and 44% of them, they are males. And mainly the age was 19 years. And this is the symptom we are talking about, and we are analyzing this type of symptoms, skin, epistaxis, oral, menorrhagia, whatsoever type of symptoms, which I'm going to analyze soon. So we have found more than half of our population, they have significant type of symptoms, and 18% of them, they have mild symptoms, and 29% of them, they have no symptoms. And menorrhagia and oral bleeding were the most common, followed by cutaneous and epistaxis type of bleeding. Let us go over the menorrhagia, where we have found that there is a certain number of our population, they suffer from the menorrhagia, where from duration point of view, there was about 26% of our population, they are suffering of less than 6 days of the menstrual cycle, while 74%, 3/4 of our population, they suffer of more than 6 days. 16% of them, they have heavy cycle more than 16 days, and 6% of them, they need to seek medical advice at any point of time. Epistaxis, again, there is 22% of our population, they suffer of epistaxis. 19% of them, they have spontaneous epistaxis, and almost 1/3 of them, they start to suffer from epistaxis while they were children. And many of them, like 1/3 of them, they have more than 6 episodes per year. Cutaneous symptom in form of bruises or hematomas has been positive in response in 23% of our population, and a few of them, they need to seek medical advice. Hematomas and muscle bleeding, it was quite few in 3% of our patients, and few of them, they need to seek medical advice. Oral cavity, it was in 40% of our population, and mainly during teeth brushing, and 18% it is spontaneous gum type of bleeding. After first surgery, there was 21% of our population, they suffer of the bleeding, and they need to seek medical advice for resuturing or resurgery. And after tooth extractions, 10% of them, they suffer of bleeding, need to go back to the dentist to fix it. As I said before, more than half of our population, they suffer of the bleeding disorder. So we run for them BT, BTT, and BFF and 100. And this is the result. Over the all total population, 22% they tend to be abnormal from the laboratory point of view, while from the significant symptoms presenters, they have 12% of them, they have abnormal laboratory test for them, mainly BT, BTT. So, in conclusion, we thought bleeding symptoms are very common among our sample, but laboratory screening tests was only positive or abnormal in 12% of our sample. So our subsequent issue or subsequent level that we will run for them, the analysis of the type of the disorders, whether it is a coagulation, whether it is platelet, whether or whatsoever the type of bleeding disorder is. And those whom term to be a bleeding disorder, we will run for them the genetic testing to look into what is the exact genetic problem among our all population. So wait for us for our next publication, where the prevalence of bleeding disorder in Saudi Arabia and bleeding disorder in Al-Madinah. Thank you, I'm ready for questions.
Okay, so thank you very much. We already have 3 good presentations from Ampaiwan, from Silvia, and from Ahmad. So this session is now open for question and answer. Let's start for this first question to Silvia. What is the impact of treatment regimens on the results you showed us?
Excuse me, what is the impact of what? Sorry, because I
The
can't hear you very
treatment,
well.
what is the impact of treatment regimen on the results you showed?
So, do you mean the impact of treatment, let's say, if patients were on demand or on prophylaxis?
Yes.
Okay, so most of the patients were on demand. However, I want to tell you that clinical data and medical data were analyzed in another publication, in another part, and so I do not have full access to all this data. I only analyze the psychological data.
Okay. So maybe we have some more question we have some question in Spanish, but I think it will be difficult to translate this. So just one question to Ampaiwan. What were the challenges for you to try this connection between your local registry and the World Bleeding Disorder Registry? What was the challenges you think you will face for this?
The challenging is we have to get more data to capture to the WBDR. So right now we just send them the minimal data only. So in the near future, maybe we can capture and send more data.
Okay. So I'm waiting for the question. Here I have some questions, but unfortunately they are in Spain, unfortunately. So I will have a question for Silvia also. Uh, do you think that uh, which kind of intervention you think will have impact to decrease all this emotional distress and to promote well-being? Which kind of intervention do you think? Yes.
So, in recent years, there is the emphasis to promote and to monitor the psychological dimension in all hemophilia patients over the time. And so I think that monitoring these aspects, during the annual visit or during the monitoring visit that patient had at the hemophilia center could represent a first important aspect to monitor also quality of life, because with aging also patients start to have some more comorbidities and some more problems, or some more impact with the multiple treatments. And so monitoring these aspects, that because the impact of treatment, the impact of multiple disease has also an impact on the emotional and feeling point of view. And so monitoring this aspect represents a first part of the intervention. In end, I also see that the hemophilia center in Italy, as well as in many countries, but now speaking from Italy, offer some important support in terms of physiotherapy, orthopedic visits, a more contact and a more established relationship with the physician, are all things that represent a big help, a big support for patients. So monitoring patients over the time with all these specialized treatments would represent a way to prevent, to increase the well-being.
Okay, so thank you for your answer. I have a question also to Professor Tarawah. In order to compare to other cohort, do you plan to assess the ISBT BAT bleeding scores?
Uh, Actually, the score we have used, it is based on the ISTH BAT score, where it has been modified for the reason of the translation and we want it to be more detailed actually. So it is almost the same like the ISTH BAT score. To compare our cohort to other cohort, I'm talking about it like in Europe or Asia or whatever. It could be a good idea to do so, but we are comparing our own cohort, like the cohort from Medina, the cohort from Riyadh, or so where else. We have choose 4 regions, so just we have finished some of those data. So still we are analyzing some more data, and we can go over the analysis and comparison between the cohorts, which is locally, to compare our cohort to the international cohort. This is a good idea. We can go ahead for that.
Okay, so I have yes, I have a question for Ampaiwan. Do you take a consent from the patient to be included in the registry?
Yes, we have
Yes.
to take informed consent from the patient and the parent to both registry, the Thai registry and WBTR.
So do you think the government is also a part of the registry, or if any form in your country?
Government is indirectly.
Uh-huh.
Directly, this one is less responsibility by the Thai Society of Hematology. And then the data will be reflected and feedback to the National Health Security Office, which is the government sector, who is responsible for the hemophilia nationwide treatment program.
Okay. So my question also to Silvia. What is actually the percentage of patients under treatment for depression or anxiety in your cohort?
So I analyzed data for mild, moderate, and severe depression. I must say that severe depression was really rare, around 2 or 3, in patients with hemophilia, 2 or 3%, was much more present, mild and moderate severe. So expressing mainly in sleeping problems or inability to do things in everyday life, and also a sense of loneliness. In patients, this was around 20% and was a higher
Okay,
percentage in comparison with control.
I see.
But it's
Yes.
important to say that we did not detect severe depression.
Mhm. Excuse, just one other question. Do you think that all this form of psychotherapy, is there any evidence that they works?
So there are evidence. There are evidence. Literature, in particular, literature presents results for some type of psychotherapy, particularly psychotherapy from CBT, that is the cognitive behavioral therapy. That is a type of therapy that is much more measurable in terms of outcomes because has a particular approach that tries to be more scientific. However, there are many, many types of psychotherapy, and all psychotherapy can work effectively. But there are more data on this type, on one of these types, that is the CBT, the cognitive behavioral therapy. In this study, we did not, investigate a type of therapy, but we just identify possible area to work with. And so we evaluate emotional health status and social and level of functioning in order to address some patients to a form, for example, of support like psychotherapy. However, in literature, in hemophilia and also in other conditions, there are evidence, but particularly for CBT.
Okay, so Dr. Tarawah, I think that menstrual bleeding sometimes are very taboo in some cultural countries, maybe like Saudi Arabia. If so, how do you deal with this? I am thinking about regarding diagnosis of bleeding disorder in young girls. How do you deal with this?
Well, we know that it is common not only in Saudi Arabia, in many countries in the region, in the Middle East. Generally speaking, bleeding disorder are common. In my place in Medina, we have the highest rate of the Glasman thrombasthenia. We have high rate of factor 13 deficiency, not like the other part of the world. So we have to deal with such a problem. Um, it is beyond of our study, but for the cohort whom they have high rate of menorrhagia, for example, we are looking for the cause of their menorrhagia, whether it is a bleeding disorder or it is some sort of gynecological disorders. We have a protocol called the Medina Protocol for Control of Menstrual Cycle in bleeding disorders. We are following that protocol where we allow the menstrual cycle to happen for those girls, for example, and we carry on. Now, for the other bleeding disorder, whether they are girls or boys, we are carrying either the local protocols for or international guidelines. For Glasman thrombasthenia, for example, we have our own guidelines or GCC guidelines, so we are following such cases. I'm not sure if you mean something related to prevention, which is unlikely. Thank you.
So do you have any other comment? So for Dr. Sylvia, according to these results, do you have project for young hemophilia adults to send resent this depression later when they will be aging? Do you have a
So
plan, for example, to yes?
So yes, we would like from this study that this study was important because it tried to identify a situation in elderly patients and across Italy. And so from this study, we also want now to to enlarge the population and to focus also in other type, in other age group. For example, it would be very, very nice to include some vulnerable ages like adolescents or children, and to see how this aspect could be monitored or change over the time. Because in any age there are different aspects, there are different problems that could emerge. And so, yes, there is a plan, but it's not at the moment we have not started yet.
If I look, for example, if I compare the psychosocial difficult aspects of hemophilia in developing countries like us, the most determinants are the fear of social rejection, access to care, difficulty to access to care, the high cost of treatment. In your setting, what are the biggest challenges, the biggest determinants of this?
So the social component is an important aspect also in Western countries, absolutely. Maybe a difference that we can see is that the social representation of the disease, the stigma of the disease, could be interpreted in a different way between, for example, Europe, Western countries, and other countries where having this disease is still a big problem for the future. However, uh, there are some areas, for example, at the level of close relationship, many patients, not only elderly patients, but also in adults, young patients, report problems at the level of intimacy and close relationship. Um, I wonder if this area could also represent a problem also in other countries, like your country or other developing countries, but probably yes. And another thing that I noticed in previous study was also actually at the social level, the problem of jobs in general. So in a previous study, we evaluated the fact that some different patients have problem in maintaining or keeping a job. And so this represents another area that could that is important to explore further in other studies. And I wonder that this area related with job may represent an issue also in other countries, also in developing countries.
Okay, so Ahmad, I know that you are very active on the Middle East and North Africa. Do you see any difference on the pattern of bleeding among all these countries?
I think yes. We are looking for a study to compare the cohorts from different countries. Um, We have a paper at this conference about the circumcision in the hemophilia patient in the Middle East countries. But we are looking to do something. It's the same like what we have done in Saudi Arabia, but to be in the Middle East. Um, we are starting the idea. We are just cooking something as such. We know that there is difference, but we want to look for something as such. Uh, Bleeding disorder, it is more common in our area, and we have a couple of publications from Saudi Arabia, from Iran, from Pakistan, show the same issues, that the things which is rare somewhere else, it is more common in our nations. To do a combined study to look for this, it is very good idea, and we are discussing how to conduct such a study all over. At least we do it in a retrospective way or a questionnaire-based way. If we cannot do it into sequencing, molecular sequencing, I mean, or testing. So we are doing something as such, hopefully.
Okay, I have also a question for Ampaiwan. For the connection of your local registry and WBDR, do you have a dedicated staff for this? And how on the WFS side it is organized?
You mean the support for the one who put data in? Say the question again, please.
You want me to repeat the question?
Yes, please.
Yes, just wanted to know if you have a specific, a dedicated staff for only connecting your local registry to WVDR. Is there any specific, any dedicated staff to do this job?
We have the staff for the physician, and we have the hemophilia nurse to help us in this job. But the hemophilia nurse is the one who taking care of hematology patients. So and also oncology too. So it is hard work. So that's why we register in Thai registry only. And then WBDR can have the data by automatically transfer that we select the specific data for WBDR. For example, infectious marker, we don't send to WBDR. But in Thai registry, we have for our own. So we just select some specific data to WBDR. And the registry of the Thai hematostasis is just run in this year, and it is taken responsibility by the Thai Society of Hematology. So it's a challenging job. It's more work.
Yes, I see. I see. I see. And do you have any cooperation between you and maybe neighboring countries on this or
No, not yet.
not
Not yet.
yet?
So maybe in the future, maybe we can share with Lao, because some of the registry is written in Thai language that Lao people can understand. But some of them are written in English too. I think other countries can share with us if they are interested in.
Okay. So maybe for Sylvia, I have a general question about well-being on elder hemophilia. How do you think really is a better way to improve well-being in hemophilia patient? I don't still only on older, but from adolescent. How do you think it is a better thing to improve this well-being?
So yes, it's a it's a big question. So let's say that it's important to discuss about hemophilia, about the disease from the beginning. It's important to involve the child and then the adolescent in discussion, in dealing with the disease, potential fear, potential negative feelings. Because when you are a child and then you are an adolescent, you start to have fears, you have to be worried about the future. So conversation, dialogue, open discussion, both with the family and with the general practitioners and the physician at the Hemophilia Center represent a very important starting point to deal with the disease in a positive way. Then it's important to to be open also from a parent point of view, from a doctor's point of view, also to be open to receive possible fear and concern of the patient, and to openly discuss with him. Um, this will give trust and also a sense of um, you know, a sense of positive growth to the patient, to be open also with friends, with the social context, with school, to deal with the disease, to sport. So at the beginning, when the hemophilia patient is very young, it's fundamental also the attitude of the family. So this represents an important imprint for the growth of the hemophilia patient. When it becomes an adolescent, it starts to be an independent boy, and again, it's very important the open discussion, the open dialogue, and the possibility to discuss about concern and fear. When this will give you the force and the strength also to cope with the adult age and then also with the elderly age. However, I think, as a very general rule, that it's important in all the hemophilia centers to give the possibility to support the patient with some form of psychological or counseling support, because during the life, everybody, not only hemophilia, but everybody could need some form of support, particularly if you have a chronic disease. So starting from these different perspectives could represent an important point.
Thank you. Thank you very much. It was not a very easy question to respond, but you make it. Maybe I have one question also for Ahmad. You show some discrepancy between the lab diagnosis and the lab results and the prevalence of bleeding symptoms. Do you what is the main challenges of hemostasis lab testing in your setting? Do you are you it is a 100% reliable, or do you have any kind of challenges on this child side?
Actually, this is very expected to have this difference between the questionnaire response and the lab testing. This is expected that somebody will tell you that I have bleeding, and then when you test them, you find that they don't. So this is expected. The reliability of the test, well, there is nowhere in the world where you can say that the reliability is 100%. There is limitation everywhere. When you do BT, BTT, BFA, you have to have a fresh sample. And all the tests, it is centralized in one lab. So to shift the samples to that lab, it will be quite not an easy job, because the sample will not be fresh anymore, particularly when you know that some regions away from the central lab, like 1,000 kilometers away. So what we have done, BT, BTT, BFA, we do it at the site. we finish the questionnaire. When we have found the response is positive, so we run the BT-BTT and CBC for those patients, I mean for the candidates, and those samples shifted again to the central lab. We repeat the BT-BTT, BFA, CBC, and again, if it is abnormal, we run the other tests like the levels of the factors, the function of the platelets, and so on. And for those, they tend to be a bleeding disorder, we run for them the molecular sequencing. So you can't say that the difference between the laboratory and the response to the questionnaire, that half of them, they said that they have bleeding disorder, while the real of them whom they have bleeding, I mean abnormal lab tests, were 12%. This is expected, and it is the same we have seen in other cohorts somewhere else. When we have these studies, you find that when you do a questionnaire based, you will end by that there is some bias. Sometimes they don't understand the question very well. What is the definition you mean, and what the definition they have understand. So the positive, it is not always positive. Sometimes positive tend to be negative.
Thank you very much. Maybe I will take one last question for Ampaiwan. Do you have any deadline? Do you think there has some timeline for the complete connections between the two registries? Do you have any proposed time to do the complete connection?
Yes, the complete connection has already done. So right now we can send the minimal data set from the Thai registry to the WBDR. We have done it already. So in this year, we started to collect more patient data to send to the WBDR, because it is the intention of the doctor that they can select that they would like to join the WBDR or not. So if they would like to join, we will send the hemophilia data.
So
we will send the hemophilia specific data to the WBDR on the purpose and intention of the doctor. Yeah. It's already done already. We already connected.
Okay. So do you plan to jump to the extended core set data or not?
No, not yet. Right now,
not yet.
We just include minimal data set, as I show in the slide. Baseline data, baseline visit for the last 6 months, and follow-up visit for the ongoing. So in each year, we plan to send to the World Bleeding Disorder Registry in each year an annual basis. So that is the way that we can obtain the annual patient individual reporting.
Okay, so is there any last comment from the speakers?
Thank you for you, Saliou, for this moderation, and thank you for WFH to give us this opportunity to meet those wonderful people. Thank you.
Silvia?
Also for the moderation. Yes, thank you very much also for the moderation and for this opportunity. Let's hope to meet in person in future.
Yes. Okay. So thank you very much for this 3 presentation, and see you. I hope see you next meeting in face-to-face format. Thank you very much for everybody. Thank you to the WFH.